let's do it.
Okay, awesome. And might I say that this is literally the very first time I believe that anyone has ever gone air doing a live interview with acupuncture needles in.
I actually think it is the first time in recorded social media history, Instagram, any online platform, that two practitioners have done live acupuncture, with one of them being an RI specialist and the other being an acupuncturist. I do agree. I think it's the first time ever in recorded history.
Yes.
So thank you for allowing me to be part of that.
I love this, and I hope that this goes wide and far, because, you know, really I believe in integrative medicine. I myself was at this clinic. It seemed like 1,000 years ago, but my daughter is now 14 years old. So I was at this clinic, and I believe in integrative medicine. I certainly didn't start off that way. You kind of want to have a child like in the bedroom outside of the fertility clinic. But, you know, it so happens that 1 in 8 have issues, or 1 in 6 now, right?
6. I think we should get into it.
Okay, great.
Sure.
Okay, so hi, I'm Mary Wong. I'm an acupuncturist and founder of a live holistic health clinic, and I'm super excited because my main passion is about integrating Eastern and Western medicine. And Dr. Ari Baratz here, I'm so privileged to have you with me.
Thank you.
From Create Fertility. And you've been, how long have you been in practice?
Longer than the needles have been in my forehead, that's for sure. But for about 20 years.
Oh my goodness, okay, so, you know, a long time. We are gonna discuss PMOS, because right now the Lancet had just renamed PCOS as polyendocrine metabolic ovarian syndrome. It's a mouthful, right?
Excellent. PMOS.
So, PMOS. So tell me, you reached out and said, hey, let's talk about this. So I would love to hear why you wanted to speak to this.
Well, thank you, Mary, for hosting this. I think your platform's excellent for this discussion, because you probably see many people with PMOS, formerly known as PCOS. The reason it's important comes back to the demographic. So probably 1 in 8 reproductive age women are dealing with PCOS or PMOS. So it's always sort of in the headlines, but when it gets a rebrand or a rename, I think it's important to refresh our knowledge of the condition, what is included in the syndrome, whether you're calling it PCOS or PMOS, what are we looking for? It's something that we're just seeing so commonly that we find ourselves discussing it often. We want to make sure that we're accurate and really touching on how it impacts the patient, the whole patient, both from a well woman or well person perspective, as well as their fertility. Yes. and their long-term care.
And I don't want to overstep that, because long-term is actually the reality. It's not just about fertility, it's about the rest of their lives. And I believe that the name is more adequately suited to the condition.
So first of all, historically, whether you call it PMOS or PCOS, the condition has been seen in women for hundreds of years. It was in the sort of the early 1930s when clinicians started to further characterize it. And that led to, in the early 2000s, there was the Rotterdam criteria, where the term PCOS was still accepted. And there were experts considered 3 main features to the condition. So PCOS, polycystic ovary syndrome, and it was the polycystic appearing ovary. It was the cycle, or the menstrual cycle irregularity, or irregular ovulation, and signs or symptoms of hyperandrogenism. That means overproduction of the male hormone, which leads to either skin or hair changes, male pattern baldness, or other changes that deal with hyperandrogenism. The problem was that every time you say PCOS, it strikes fear. Oh my God, doctor, do I have large cysts in my ovaries? Do I have a cancer? The doctor said I have cysts. And it really was losing the true essence of the condition. The essence of the condition is not the ovarian appearance. It's the new name, the polyendocrine metabolic components, that are really, I would say, what drives PMOS. So the idea that the brain is not interacting properly with the ovary, and that leads to other downstream effects like liver dysfunction, adrenal dysfunction, cardiac dysfunction, even mood dysfunction, depression. And so yes, even though irregular cycles and a polycystic appearing ovary were probably some of the initial findings, rebranding it PMOS allows people to realize this is the true essence of the condition, the polyendocrine component, the cycle irregularity, and the hyperandrogenism that we see.
So I'm just going to add in here, because this is an integrative chat. So in Chinese medicine, we've actually been seeing these conditions, and it's been documented for like 2,000 years. And what we call it is spleen qi deficiency with phlegm dampness. But really what it talks about is this deficiency of the spleen stomach, meaning like the metabolic challenges that is involved in this, and then the difficulty of like transforming the food and churning it into essence that it's utilizable. And so that equates really to like insulin resistance.
Yes,
in
absolutely.
you know, it's like the same thing but different languaging.
Right. So when you talk about metabolics, the insulin receptor, which is one of these master switches in the body, is a key player. We know that in the first group of women where PMOS was described, these were usually obese women, frankly diabetic, not just insulin resistant, and they were very sick. These were women that were experiencing hypertension, like severe cardiovascular disease. Many of them were dying from endometrial cancer because of overgrowth of the uterine endometrium, and they certainly weren't getting pregnant and they weren't ovulating. It's definitely much more than just the ovary, and again, this new name captures it. And we also know that early therapy maneuvers were to reverse that. So control the ovulation, control the weight, the lifestyle. We know that that can reverse a certain element of the PMOS. So again, speaking to the holistic nature here, if you just treat the ovulation, yes, you might help our fertility patients, but you're not treating the underlying chi. The needles are still in me, right? Okay, I think that's why.
The needles are still in. So then let me ask you, like when a patient comes to you and they're actually diagnosed with PCOS or PMOS, and they're quite distraught because it's a bit of a shock to have any kind of diagnosis, frankly. So what do you say to them? And what are your tools? How do you help? And is this like a prison sentence?
Right. So first of all, when someone comes to me today and says, I have PCOS, I say, PCO what? I'm just kidding. No, obviously many patients are still using the term PCOS, but typically when they present to the fertility physician, it isn't their first presentation. Usually, because irregular ovulation, irregular menstrual cycles is one of the hallmark conditions, they've usually presented earlier to their general practitioner or gynecologist, and very often it was the well woman side of PMOS control that was driving, meaning they would be on the birth control pill, or they would be looking for weight loss treatments, or even diabetic treatments, but they really weren't focused on fertility. So many patients have already been accustomed to this concept. In fact, that's one of the major reasons they're seeing us is not them saying, I have PMOS, they're saying, I'm not getting pregnant or I'm having irregular periods. So many have been primed, but for some of them, it's actually a shock. And that you actually give a name, whether it's PCOS or PMOS, you're saying, look, they tell me their menstrual history, they tell me their medical history, we examine them, and I say to them, look, you have all of these features, you have PMOS. And the initial, I do agree with you that the initial reaction is, oh my God, this is a death sentence. And I do remind them that it is a very treatable condition. The long-term prognosis from a fertility perspective is actually very good if we treat the underlying problem. And it becomes a risk factor. So maybe it's an opportunity to reverse some of those chi out of control factors. So we try to work on weight loss, we work on blood pressure control, glycemic control, diet, exercise, so that we can, beyond the fertility clinic, improve their long-term care. Not to mention that we don't just focus on getting people pregnant, you and I, we also focus on healthy pregnancies, reducing miscarriages, having good maternal and fetal outcomes, both near-term and long-term. Uncontrolled PMOS is associated with all these downstream problems as well. So even though we discuss all of these issues, there are many positive reactions and ways of managing them. In terms of management, we always start with lifestyle. So and that's a multidisciplinary approach, looking at where can we improve their intake, how can we improve their output in terms of their activity, and making sure there are no frank disorder, like that they aren't frankly diabetic or overtly hypertensive. So it will involve the holistic team, the reproductive endo team. It might involve endocrinology as well as their general doctor. We might even involve a cardiologist, depending on the nature of that. But usually between the two of us, I think we can manage most of it. And then very shortly after that, including a full reproductive workup, we move into something called ovulation induction.
A lot of people will come and maybe they're not ready for their fertility clinic. They do have a diagnosis of PMOS, and we definitely start with lifestyle. Like that's the first rung, like the highest tier. Like let's go with that, and that's treating the root. So we look at exercise, and for women with PMOS, typically what works best is not to increase the cortisol so high, like doing these crazy HIIT classes, but doing more controlled, like heavier weights, because it helps the metabolism work a little better, right? So that's one piece. And so not overdoing aerobics, more weights, walking, but then something like how you eat. And again, I told you that, it's been around for 2,000 years, so we speak to what to eat, what not to eat. One of the things about spleen chi essence, we want to be really kind to our metabolism. So we typically say, it takes energy to increase the food and drink to body temperature. So we tend to say, you know what, let's not create too much fuss for your metabolism and have warm foods, warm drinks, easily digestible. That said, in terms of smoothie culture, because they pulverize
which culture?
the smoothie culture,
Smoothie.
right?
Oh, drinking smoothies.
Smoothie drinking.
Sorry, the needles are still in me.
Oh,
Sometimes I can't hear. Sorry about that.
We're not crazy about smoothies because it's pulverized to the degree that it becomes quick sugar. And what we know that if there's insulin resistance, you're just putting sugar straight in your system, which is not so great.
Well, I want to definitely encourage that initial approach. I mean, not smoothies, the lifestyle, because whether you refer to the condition as PMOS or PCOS, the initial research and our knowledge of whatever way you want to refer to the condition still holds. And we do know that regardless, I know that you're very particular on exactly which diet they're on, but much data in the past has shown that as long as you can achieve whichever diet is tolerable, sustainable, workable, as long as you can get about 5 to 10% reduction in your peak weight, you will already see improvement in PMOS. And so they've actually looked head to head at different diets, high carb, low carb, high fat, low fat, restriction, fasting, intermittent fasting, and I don't think that there's one diet that's superior other than the diet that you can maintain. And we know that one size doesn't fit all. So, and that also holds for physical activity. The bottom line currency of PMOS, at least from a lifestyle perspective, is the scale moving, right? Is your waistline shrinking? Is your BMI changing? And if it's high impact, low impact, hits, that's where I would push back a little bit and saying that, you might have people who are less athletic and want to do more low intensity, low weight. You might have people that want to do more weight. To me, it's a bit superficial. I'm more focused on, is it actually moving the needle?
Moving.
Which I hope is not moving. And so that, I would say that's what I find is most helpful with PMOS lifestyle. One of these, if you have a smartphone or a smartwatch, step count, I find very helpful. Routine weight checks, as difficult as that is, and maybe having one of those apps that has that integrated intake, food intake, like almost like a nutrition calculator.
Right, calculator, yeah.
So that you can actually see what is your calorie intake per day versus how much you're burning. And again, it gets a bit nuanced, but it doesn't matter which of them you use. That's really the net of it all, is are they burning more than they take in, as difficult as that is?
I actually love that you're saying this, because in TCM, we actually say there's no one size fits all. Same thing, right? It's not generic. And, if we're going to go and talk about diet, I think the most important thing, and I've done this myself, both my parents are type 2 diabetics, and so far so good, 58, and I'm not at all. And it's, the lifestyle and what I've done.
You say 28? Sorry, okay. Sorry about that.
What I loved was doing the continuous glucose monitor, and I literally stuck it on my arm, did it for 2 weeks, and some of the shock was like, oh my gosh, I can't believe this little innocent looking navel orange, one of them, spiked my blood sugar to like pre-diabetic level. I was like, what? So really, I personally think that everyone should try it.
There is another major player in this space, and the big O word, Ozempic, or the GLP-1 agonists. So that class of drug has also really driven the narrative on PMOS. And that actually might be one of the reasons why PMOS went through its rebound in the last couple of years, because people have been talking about why PCOS is a misnomer, but because there's so much research coming out on the metabolic impact and how we can make PCOS and PMOS that much better with the aid of some of these drugs, and that they're so fast acting, that's also driven the conversation. So that might be another tool that we use in the clinic. Some patients will come see us with this blend of woman interest as well as infertility, and if they're actually severely or extremely obese and PMOS, we might say, let's take a 2 or 3 month hiatus, work on, it doesn't matter which GLP-1 agonist they're on, with the aid of their family doctor, or endocrinologist.
Oh, so, but you're prescribing it, no?
We're not really prescribing because we're not using it as frequently, but we are collaborating with, we could prescribe it. I mean, it's a commonly used drug, but usually because we have a referral stream, I typically request that they see their family doctor because they do need to take the meds on a regular basis. They also have to follow up every 4 or 6 weeks. And it's also not just there for the fertility piece, it's there for long-term care as well. We aren't really putting people on it. Well, they should not be on it when they're trying to conceive. There needs to be a bit of a hiatus. And also for some of the procedures that we do, we need to take a bit of a break from, I'm using Ozempic, but it could be any one of the GLP-1 agonists. So very powerful drug, but if we're using it, we have to agree through doctor-patient negotiation and discussion that we'll take a 2 or 3 month break, give the Ozempic or GLP-1 agonist a trial, not conceive during that time. If conception was to occur, we would immediately stop the agonist. But
What's the fear?
What's the fear? Well, I mean, this is still a relatively new drug.
Yes.
The fear is that there could be some theoretical teratogenic effect, something on the embryo or fetus. So far, all the babies have been healthy. There are some concerns about gastric emptying and sedation procedures that we do, but in general, again, because it's a relatively new drug and it's also fast on, fast off, the recommendation is to stop either when you diagnose pregnancy or within a certain time frame, depending on the drug, leading up to trying.
When it comes to doing a procedure like an egg retrieval, how
sedation.
far in advance would you stop the GLP-1s because of the delayed gastric emptying?
Yeah, so we usually recommend about, again, they have different dosing regimens, but about 7 to 14 days, so like 1 to 2 weeks before. Some of this is theoretical. I'm sure there have been some patients that took their dose when they weren't supposed to. The sedation that we use during egg retrievals is very subtle, but it also depends on the comorbidity. Is the patient, does she have sleep apnea? Is she morbidly obese? Is she hypertensive? Obviously, then we wouldn't even maybe do an egg retrieval on them. Usually it's within 1 to 2 weeks before. So when we start the IVF stimulation, we do an audit of their drugs. We say, Mrs. So-and-so, please make sure you don't take any further Ozempic or GLP-1.
That's great.
Doing TCM, do you have any no restrictions on
it? When people are on GLP-1s?
Yeah.
No, not at all. Yeah, so we will concurrently use it, but other strategies like through acupuncture, what we know is that it increases blood volume, and I've seen it where people are anovulatory, so they're not getting their menstrual period even, they're not ovulating, and we'll do the acupuncture, it actually helps them to ovulate again.
To be clear, if they were to conceive on a GLP-1 agonist, that would not be grounds for termination at all. I would definitely support that pregnancy. We would stop the GLP-1 when the diagnosis of pregnancy was made.
Yeah.
And then we would manage all the other comorbidities, check their sugars, because very often people are on Ozempic not just for weight loss, but for glycemic control.
Yes.
So again, looking at the whole person, and we're not just about getting them pregnant, keeping them pregnant, and having a healthy ongoing pregnancy, healthy mom, healthy baby.
That's awesome. For those of you tuning in, you might notice that Dr. Ari Baratz here, our fertility doctor, he is having some acupuncture. He's not just walking around.
Hang on. You didn't tell me you were putting a needle in me. Is there a needle in me right now? This is news to me. So the diagnostic criteria for PMOS is still the same, right? We still look at menstrual irregularity as one of the diagnostic criteria, oligoovulation. We look at signs and symptoms of hyperandrogenism. And then we still use the ultrasound. Like the PCO appearing ovary is still a feature. It just isn't, it's not a requirement. It's also, there are other newer tests that we use, like you may have heard of the AMH test, the anti-Mullerian hormone. So it was never considered part of the core diagnostic,
right.
But there's no question that if you're going to have this polycystic appearing ovary, a very large reserve, you're going to see high AMH levels. And so there's been many studies correlating high AMH with a PMOS stigmata.
Have you ever seen a PMOS patient without a high AMH?
Yes, I have. So there are other situations where people, first of all, we can have mixed picture. That was the problem with the PCOS term, is that it didn't include other variants. So there can be women who actually might have a mixed hypothalamic picture, or other reasons why they have some of the PMOS features. It is possible maybe that they had one of their ovaries removed for another reason. They may be a smoker or other comorbidities or other toxic exposure, so that might artificially reduce their AMH. And AMH is not a perfect test, right? It doesn't record in everyone, but for the most part, an elevated AMH is typically consistent with PMOS, and a low AMH does not necessarily rule it out, but it is possible to have an average AMH. It doesn't have to be through the roof in terms of PMOS.
So if you had all the time in the world and someone comes to you, they have PMOS, what would you say to them?
How much recording time do we have? Well, the first thing I always say is once we've excluded other factors, and again, even in the PMOS diagnosis, even if they were just coming to me for their hyperandrogenism, their acne, their hair, and not really active fertility, we always want to make sure there are no other hormonal issues, that their adrenal glands are working well. Adrenal glands, those are important. That they don't have any thyroid dysfunction. Again, other adrenal hormones are in check, and ruling out other drivers of either high cortisol or high androgen. But if we've ruled everything out, and we've ruled out other fertility factors like male factor or other structural factors, I usually tell them, Mrs. So-and-so, as unfortunate as that you're in the fertility clinic, and as unfortunate as that we have PMOS, your overall prognosis is very, very good. And that is an encouraging thing to hear, because before you mentioned, is PMOS, a death sentence? Is it really a non-starter? And I would say when you compare it to other diagnoses in the fertility clinic, PMOS is not just amongst the most common, but amongst the most treatable. Mm-hmm. And for very often, PMOS, people worry, if they're coming to the IVF clinic, they're doing IVF, but we have a lot of success with ovulation induction, lifestyle, insemination program if required. In fact, many of them will conceive, they won't even need their IVF therapy. So it's not to say that IVF isn't part of their treatment, but they're not locked in. It's not like other factors like severe male factor, tubal factor, severe endometriosis, where it's either IVF or unlikely to conceive. That is a bit of a silver lining. I don't ever want to sugarcoat any of our diagnoses. Look, we just exited Mental Health Awareness Month, and certainly there is a reproductive component to that. But if I had to pick a diagnosis, PMOS is probably one of the top in terms of what we can manage effectively and that we're comfortable managing.
And we're going to talk about integrative therapies. So when you have a new patient in front of you and they ask about, should I try acupuncture? What would you say to them?
Let's just be clear, there is a needle in my forehead right now. I always say from personal experience, because I've had many needles. I actually walk in just like this. I have a needle in my forehead and the top of my head. Well, I tell them that your approach to any problem, if you were not in the fertility clinic and you had a problem in front of you, you were a scientist or a mathematician or a teacher or a lawyer or any profession, you would not just take one tool out of your toolkit. You would use all the available tools, and you would use the ones that are most effective at that moment. That will lead to a long-lasting solution. So when you look at it that way, if you apply it to the fertility care of PMOS, that is not just visiting Dr. Baratz at the Create Fertility Center, taking some tablets and hoping for the best. It involves doing a full 360, looking at all the modifiable factors. Some of them will be non-modifiable, and that's our job. And that will involve you. So that's usually the gist of the conversation. I always ask people, what is your desired family size? Like, are you the kind of person that is comfortable with a smaller family or a larger family? What is your comfort with technology? Because we quickly will move into some of those items, and I want to make sure that they are not over or underwhelmed, that they don't feel pressure to push the tech, but also don't feel pressure that if they don't use it, that they're missing out.
Let's be real, and you actually mentioned it earlier, sometimes it's not IVF or IUI, sometimes they just get pregnant naturally, just using all the lifestyle stuff and education, right?
That's why it is quite important to establish from the beginning, what are the goals? I mean, are the goals well women care, or are the goals more family building? And the goals actually might be somewhere between. It might be fertility preservation. In fact, that's another upside of PMOS, is that typically it's associated with a large egg reserve. And those women, even though there may be questions about the quality of eggs at times, they are usually high performers in fertility preservation. And so that science is an option for them too. While they're trying to work out their other lifestyle issues and general health, they may decide to do egg or embryo freezing in the interim.
So this is where in Chinese medicine we typically say, follicular genesis, it takes time for the developing egg to mature. And kind of like you have a car, you need to gas it up regularly. So in Chinese medicine we say, well, we need to stimulate the ovaries to help get the oxygenation, the nutrients to get there, and even the hormones, right? Because sometimes if there's like endometriosis or tissue adhesions, there's lack of blood flow. The blood flow carries a lot of all of this stuff in it.
Well, one of the original theories, because we talked about how PCOS, PMOS was diagnosed probably in the 18th century, but it really was in the, let's say, earlier part of the last century where people were starting to research more And there used to be surgeries that were done for PCOS, PMOS, either resecting part of the ovary or drilling the ovary. And no one really fully understood the mechanism, but it has been suggested that, and it's not really the main first line care, it's probably fourth line, if that at all, but the original thought was that you're letting all these little cysts and you're liberating them, but really what you're probably doing is improving blood flow to the ovary, injury repair model, reducing the stromal component, which has all that androgen production. So that's probably what the surgery was doing, which is in line with what you're doing. It was almost like needling at the level of the ovary. I still have a needle in my forehead. Okay.
So tell me.
Yeah.
I just put the needles in you. Did it hurt?
Honestly, unless you told me I had the needles in me, I wouldn't have even known.
So right now you don't even feel it at all?
Do I have needles in me? I don't even. It feels great. In fact, I feel lighter. I do. I'm being totally serious right now. Like, I feel like I'm floating, but I'm not. My feet are on the ground. No, it's a great feeling. I really thank you for this.
Oh, absolutely.
You liberated my follicular thoughts.
Follicular thoughts. Well, here's what's really happening in action. So we've liberated the endorphins because what we know is that it increases.
Take it out now.
Sorry?
Take it out now, or you're not?
I can take it out
Okay.
right now. I guess I can do it while
Well, I'm talking out while you're talking.
Yeah. So with the acupuncture, what happens is that we're literally tapping into the endorphin system. So it releases it. And so it's like your own little drug, which is amazing that we're tapping into. Oh, you're going to hold it for me while I talk? And you know what? People actually do this. So, if you're not getting acupuncture, and certainly I don't recommend you to do it on your own, so we just do this.
Just want to show everyone, this was in me. This little needle, this little samurai sword.
Samurai sword.
That little needle was right there. That was in me. Yep.
But not the whole thing.
Not the whole thing, not the whole. Just enough to cause.
Yes, yeah, and it stayed in, right?
And it stayed in for the entire interview. First ever recording, I think, in humankind.
I'm not 100% sure, but I'd like to believe that.
I'm pretty sure.
Yeah.
As sure as I am that needle was in me, that this was the first ever live REI TCM collab. Right back at you.